Hello everyone, my name's Jamie Burrows. I'm going to give a presentation on how modern slavery can be identified within a healthcare setting, and we'll think about how this should be a public health responsibility. The aims of today's presentation are to define modern slavery for those who don't know. I'll outline the size of this global issue, we'll discuss how it intersects with the healthcare system, and explore what can be done in an emergency department setting in particular, and consider further areas for research in the future. Modern slavery and human trafficking are terms which are often interchangeable in the literature. They do mean different things, but they intertwine to create a concept. So modern slavery is situations of exploitation that a person cannot refuse or leave because of threats of violence, coercion, deception, or abuse of power. The human trafficking element is recruitment, transportation, harbouring, or receipt of these persons. It is worth noting that human trafficking, contrary to popular belief, does not always have to occur across a border or involve movement to another country. So modern slavery and human trafficking become umbrella terms for lots of situations of exploitation that are present in the world. So we've got from child soldiering to forced marriage to modern slavery present in construction sites, domestic households, agriculture, in fishing boats in Asia, within the sex industry. This is in developing and developed countries, and there's no country that doesn't have modern slavery in it. There are estimated to be 40.3 million people in positions of modern slavery today, and it's the fastest growing criminal activity in the world, grossing some $150 billion a year. Every race and gender and socioeconomic group is affected by this, with 70% of victims being female and 30% male. Unfortunately, 25% of victims of slavery are also children. We can consider the individual health impacts like this by thinking about the element of exploitation and the effect that it has on one's health. So intimidation leading to a whole host of mental health issues like post-traumatic stress disorder, anxiety, depression, substance misuse. Violence and physical violence can lead to injuries. The isolation and neglect that goes along with being enslaved can lead to someone neglecting their own chronic illnesses, and often we see a delay in diagnosis of chronic illnesses or cancers in someone who has been unable to leave the house or unable to see a doctor for some time. Sexual exploitation can lead to sexually transmitted diseases, unwanted pregnancies, and other gynecological issues. This is an illustration of how not only does modern slavery have individual health effects, but this is a global health issue which should be addressed in a public health manner. If we consider the numbers affected by HIV, estimated at 37.9 million, then 40 odd million of people in modern slavery deserves the same level of intervention. Here we can see the different sectors that modern slavery is present in, the different exploitation-related risks, which filter down to have a global health impact to include infectious and non-communicable disease spread, occupational injuries and disability, psychological morbidity, which often goes on much longer than the period of slavery or abuse, increased financial insecurity due to debt bondage mostly. And then we see this generational cycle of hazardous labour within some countries and communities. Zimmerman and Kiss in the same study go on to depict the socioeconomics of slavery, and around the outside we can see again similar concept as 2 slides ago of the exploitation leading to the certain type of harm, and then inside that we've got the trafficking or modern slavery journey, so right from pre-departure to within that destination country, and then when a person returns to safety again, the effects and the socioeconomic effects are compounding and continuous. In the middle, we've got some structural drivers and higher level issues that really fuel this problem. So inequalities, globalization, extended supply chains, and weak labour governance. People in positions of modern slavery are attending the healthcare system. Studies show that 68% of those in situations of trafficking or slavery attended a healthcare setting and during their time of captivity, and the majority of those were actually going to an emergency department in particular. Another study showed a higher rate again, that 87.8% of sex trafficked individuals attended an ED during their time of slavery. And a California study which looked at screening women aged 80 to 40 for a lifetime experience of sex trafficking. When identified victims were asked, 80% of those had actually been to an ED in the last 2 years, but had never been identified as being in such a situation of exploitation. Despite people in slavery and trafficking attending our emergency department, the information amongst healthcare professionals is lacking. A study in the NHS interviewed NHS workers in the UK, and it was found that 86.8% of those lacked knowledge on identification and management of victims of slavery, and 78.3% never really had sufficient training in the topic. Beyond the education of healthcare workers, another way to intervene with the health of those in slavery is to screen for it in our emergency department. One study, the same study in the Californian ED that screened for sex trafficking in ladies 18 to 40, found that actually a screening tool was more sensitive than physician concern or clinical acumen alone. The Vera Institute is a gold standard screening tool which is used in social service situations, and it's not quite short enough, succinct enough, or usable enough in an emergency department. When screening a victim of a potential victim of modern slavery, it needs to be done in a very dignified and sensitive and controlled manner. The patient should always be alone, away from the potential perpetrator. It should be in the appropriate language. Privacy and dignity should be maintained, and we need to provide a non-judgmental, trauma-informed care to these patients. This is challenging in an emergency department with all the competing priorities of urgent medical, acute medical issues. We don't always have the time and the space to implement this screening tool in the way that we would like. It takes time to get the language correct or deliver the screening in the appropriate language, and all while we need to preserve dignity and provide this trauma-informed care. It can be really tricky. One study which is looking to validate a screening tool for use in the emergency department is RAFT. It's basically adapted the Vera Institute screening tools but made it appropriate to ED. It's ongoing. It will go on for about 3.5 years, and it does provide some promising potential for giving us a validated tool for use in the emergency department. It is worth noting that the data collectors in their study, however, are intensively trained, and I just wonder about ongoing applicability of how can an everyday emergency department physician or nurse apply this screening tool in their ED without the intensive training that's needed. That was a whistle-stop tour of modern slavery today and its intersection with healthcare. And in conclusion, we can see it's a growing issue with both individual and public health implications. Persons in positions of modern slavery are attending our emergency department, and the health professional knowledge around this issue is lacking. Screening has been shown to have its benefits over clinical acumen when it comes to identifying these vulnerable populations. But I think future research is really needed on how this validated screening can be pragmatically applied in a busy emergency department day in, day out with all the competing interests.